request you to keep the sessions short, crisp, and well restricted in time.
Our first session is on respectful maternity care. Following an emergency, MMDU Sadhupur is not able to join us today. So we extend our warm invitation to Dr. SPS Goraya and Dr. Arshnur from MMI MSR Mulana to shed light on the importance of providing compassionate, dignified, and quality maternity care to all women.
The session will be chaired by Dr. Ragini Agarwal, Dr. Krishna Sangwan, and Dr. Kamlesh Datta.
So we welcome you, ma'am.
Good afternoon, everyone. I'll be saying few words on the very burning topic of our labor room and our wards, that is respectful maternity care, which is not a luxury but a universal right of every child-bearing woman. The notion of safe motherhood must be expanded beyond the prevention of maternal morbidity and mortality to encompass respect for women's basic rights. Every woman, every newborn, everywhere has the right to access to quality care. The general principle of a rights-based approach to reproductive health includes accountability, participation, transparency, empowerment, non-discrimination, and entitlements at its very core. White Ribbon Alliance and its partner in 2011 developed a Charter on Universal Rights of Childbearing Women to align the concepts of international human rights laws and mistreatment of women seeking maternity care. This charter identifies 7 universal rights of a childbearing female. These include that the female, she should be free from all the harm and the ill treatment. She has the right to be informed. For her consent and refusal and respect for her choices is of utmost importance. Her privacy and confidentiality should be respected, and we should treat her with dignity and respect. There should be importance should be given to the equality, freedom, and she should be free from the discrimination, and equitable care should be given. Every woman has the right to access to health care and to the highest attainable level of health. Liberty, autonomy, self-determination, and freedom of coercion are equally important. The White Ribbon Alliance has identified the 7 categories of mistreatment which the childbearing women may suffer. These include the physical abuse, non-consented care, non-dignified care, discrimination, abandonment, detention, and non-confidential care. These are few of the United Nations Human Rights Council statements in support of the respectful maternity care. A human rights-based approach is about health and is not about the isolated pathologies. It is premised on empowering women to claim their rights and not merely avoiding maternal morbidity and mortality. Mayors are required to address the social determinations of women's health that affect the enjoyment of civil, political, economic, social, and cultural rights. Applying a rights-based approach to the reduction of maternal mortality and morbidity depends upon a just as well as an effective health system. Ensuring women's sexual and reproductive health rights requires meeting standards with regard to health facilities, goods, and services. The design, organization, and coordination of components of health system should be guided by fundamental human rights principles, including non-discrimination, equality, transparency, participation, and accountability. And states are required to use maximum available resources for the progressive realization of the economic, social, and cultural rights. And if resource constraints make it impossible for the state to fulfill women's sexual and reproductive health rights immediately, the state must demonstrate that it has used all its resources at its disposal to do so as a matter of priority. Now, the various barriers in implementing respectful maternity care are the policy and management, the lack of infrastructure and the resources, the lack of knowledge, skills, motivation, ethical, economic, and socio-cultural aspects, and interpersonal relations and community factors. Now, to implement respectful maternity care on the ground, it requires a collaborative action by all the stakeholders, including the policymakers, the healthcare providers, the community, as well as the patients. Education and training should be continued. The most important factor which is usually ignored is the care of the healthcare providers themselves, like the safe working condition, the reasonable working hours, the physical and the psychological support. The question of rights, it is not a question of the rights of only a childbearing female, but of every female who will embrace the motherhood sooner or later. Thank you.
Now we will show you the prize-winning videos from Sector 32. This session was given to Ambala people, but they have a critical three emergencies and they could not reach. So here only these drills were done and they won the national prize. We are just playing them. The two scenarios where they are not aware of respectful maternity care, and the second scenario where the patient has a very positive childbirth experience. Sound cut, audio नहीं आ रही.
बच्चे कितने हैं तुम्हारे? मेरे अब से दो। क्या बच्चे हैं? एक लड़का एक लड़की। तो दो बच्चे थे तो क्यों लड़का और लड़की? तीसरा बच्चा क्यों किया तुमने? मैम गलती से हो गया। ऐसे कैसे गलती से हो गया? रानी नसबंदी करवा रही थी, प्रॉपर्टी करवा रही थी। तुम्हें क्या लगता है? बच्चे करते हुए डर नहीं लगता, बट प्रॉपर्टी करवाते हुए तुम्हें डर लगता है। प्रॉपर्टी खराब ही नहीं है। आखिरी महीना कब आया? मैं खाना चाहिए। पेट में दर्द कब से हो रहा है? मैंने कल रात से हो रहा है। और सांस कब से फूल रही है? हो गया। पेट में दर्द है, पीठ में भी जा रहा है, टांगों में भी बहुत दर्द हो रहा है। आयरन कैल्शियम तो खाया नहीं होगा तुमने, ना ही किसी अस्पताल में दिखाया होगा। कितनी बार गई हो अस्पताल? एक बार गई हो। रानी कम से कम 4 बार तो अस्पताल जाना चाहिए था ना, क्या करी थी घर बैठी?
Judgmental behavior.
अब तुम्हें नीचे भी चेक करेंगे, फिर बाकी से चले जाओ। 9 महीने में जाना ही है मैंने अस्पताल, अब आए चले अस्पताल। कहाँ आई तुम जूते पहन के अंदर? बाहर इतना बड़ा बड़ा तो बोर्ड पे लिखा है जूते बाहर उतार के, और डॉक्टर साहब ने बताया बाहर उतारो जूते, फिर चले जूते पहन के। तुम क्या लगती हो इसकी? तो पहननी थोड़ी ना पहनिए मेरी, तुम चलो बाहर।
Rude behavior.
सिस्टर जी वो सेंटर पीवी वाली पेशेंट कहाँ है? मैम की सेंटर मैम यहाँ पे पहले से मरीज लेटा हुआ है। मैं कहाँ पे लेटूँ? ऑलरेडी पहले मरीज लेटा हुआ है। और मैं खाली बैठा है तो मैं खाली वाला लेटा हूँ। जल्दी लेटो। क्या कर रही हो? मैं पर्दा तो करा दो प्लीज, क्या कर रहे हो? सारी तुम्हारी कैसी है? कौन दी है तुम्हें?
Privacy not maintained.
Thank you so much, and it was indeed a very beautiful session for the presentation of a respectful maternity care.
Up next, we have a critical drill on eclampsia led by Dr. Ruby Bhatia, Dr. Vidushi, and Dr. Sanjum Malik from MMIMSR Mulana. This is an essential drill considering the severe implications eclampsia can have on maternal and neonatal outcomes.
This session will be chaired by Dr. Meenakshi Chauhan, Dr. Satwant Kaur, and Dr. Rachna Goel. We request you, ma'am, to come forward for the session, please.
The drill will be performed in that hall. If you like to be here, it will be relayed here.
Good morning, everyone. On behalf of the Department of Obs and Gynae MMI MSR, under the guidance of Dr. Ruby Bhatia, Professor and Head of the department, we present to you the eclampsia drill. The participants along with the roles of the drill are Dr. Vidushi as the consultant, Dr. Sanjum as the consultant, Dr. Arushi as the JR2, Dr. Tanya as the JR1, Dr. Mandeep as the pediatrician, Dr. Ruchika and Radhika as the senior staff nurses, Dr. Hemant as Pooja's husband, Dr. Anand and Ahana as the presentees, and Dr. Manpreet as the Pooja's mother-in-law. As you all are aware that eclampsia is an obstetric emergency. It causes 8 to 36% mortality. Most of these mortalities are prevented by timely interventions, teamwork, and by following standardized protocols. So it is very important for every doctor to be fully prepared to deal with such cases. The objectives of the eclampsia drill are recognition of the symptoms, emergency response protocols, seizure management with ABC and magnesium sulfate, medications like antihypertensives, maternal fetal assessment, team coordination, effective communication, post-seizure management, debriefing, safe motherhood with the discharge of mother and baby, post-discharge care. Eclampsia tray should be ready 24/7 and a fixed position so faster and stress-free management can be done, thereby reducing the maternal mortality and morbidity. The eclampsia tray will now be demonstrated by Dr. Anand and Dr. Ahana. The contents of the tray are injection magnesium sulfate, injection labetalol, injection lignocaine, injection furosemide, tablet nifedipine, tablet labetalol, injection phenytoin, blood collection vials, hammer, BP apparatus, disposable syringes, surgical gloves, oxygen mask, mouth gag, cannula of various sizes, fixative tape, spirit swab, IV fluids like RL, IV set, Foley's catheter, and a Eurobag. Scene of Obs Gynae emergency room where a patient of antepartum eclampsia with period of gestation 33 weeks, 4 days has just arrived. The patient is shifted to the eclampsia room as antepartum eclampsia is a high-risk condition which requires multidisciplinary approach with one-to-one nursing care, so anesthetist and ICU are also informed. After 15 minutes.
Pooja, okay, bolo. Ma'am, she is not responding to verbal commands. Ma'am, pallor is present, icterus absent, lymphadenopathy is absent, clubbing sinus is absent, and ma'am, pedal edema, it is present, ma'am. And on auscultation, ma'am, on auscultation, bilateral chest is clear and cardiovascular system is normal. Dr. Mittal, please catheterize the patient. Dr. Radhika, please bring the catheter.
Half an hour has passed and the patient seems to be stable. So now we catheterize the patient.
Foley's catheterization done, urine is clear, 900 ml. Do a parabdominal examination. On per-abdominal examination, uterus is irritable, longitudinal lie, cephalic presentation. बस में कुछ
oxygen on floor?
Yes, ma'am.
Don't worry, Dr. Mittal. This is a transient bradycardia. It may improve with this resuscitating agent.
After 15 minutes.
Ma'am, my BP is still 135 again. Sister, give her IV Lapitalol 80 mg again. IV Lapitalol 80 mg given over 2 minutes. Dr. Mittal, how is the fetal heart rate now? Ma'am, now it's improved. It's 140 beats per minute now. Ma'am, what is the maximum dose of Lapitalol we can give to the patient? A total of 220 milligram is given in the range of 20, then 40, then 80, and then 80 again. Now we will do a quick sonographic assessment. Sister ji, ultrasound machine or probe दीजिए.
If the facility is available, we do a bedside ultrasound to rule out abruptio placenta.
Dr. Tanya, note down. This is a singleton pregnancy with cephalic presentation. Liquor is borderline. Placenta seems to be fundo-anterior. And there is no evidence of retroplacental clot. But the effective fetal weight is 2.3 kg. Dr. Tanya, please start steroid course for that patient.
जी, give 12 milligram beta methaxone IM.
Milligram beta-methazone IM given.
Now we will do a PV examination. Sister ji, PV tray.
Per abdomen examination has been done. Now the consultant will proceed with the per vaginal examination under aseptic conditions.
Dr. Tanya, note down. On PV examination, बस आराम से बेटा हो जाएगा. On PV examination, cervix is 4 to 5 centimeter dilated. 50 to 60% phase. Membranes are plus. Sister ji, copper दे दो. Now we will rupture the membrane. Membranes are ruptured and thin meconium is present. No, thin meconium is not an indication for cesarean section. Still her fetal heart rate is restoring. Sister ji, please prepare low dose oxytocin. Now we will augment the labor. Dr. Tanya, please take informed consent from attendant और blood arrange करने के लिए भी बोल देना.
High-risk consent in the view of eclampsia and prematurity is taken regarding maternal prognosis, risk of maternal PPH, pulmonary edema, need of ventilatory ICU stay, need of blood transfusion, risk of cerebral hemorrhage, breast, multi-organ failure, NICU admission, fetal prematurity, respiratory support in the form of CPAP and ventilator, RDS, and hyperbilirubinemia. Definitive management of eclampsia is termination of pregnancy. In this case, the Bishop score is good, so we will augment the labor with artificial rupture of membrane and oxytocin to achieve vaginal delivery after 4 hours.
Vitals are stable. Pulse rate is 96 beats per minute. BP is 130 by 90. HCO2 is 98% on room air. Respiratory rate is 16 cycle per minute. Urine output is 100 ml and clear. flexions are present. And adequate contractions are. Sister, give her the maintenance dose of magnesium sulfate. Okay, give her.
Maintenance dose of 5 gram 50% solution magnesium sulfate along with 1% 1 ml xylocaine given as deep IM.
Dr. Tanya, put the patient on continuous CTG monitoring and keep a check on vitals.
The patient is kept under observation, blood pressure charting is done, input-output charting is done, and the labor is monitored by partograph. After 1 hour.
Dr. Tanya, how's the patient?
Ma'am, patient seems to be stable. Her pulse rate is 92 beats per minute and BP is 130 by 90. Ma'am, on her abdomen examination, good contractions are present. And ma'am, I think the patient is bearing down.
Yes. Patient is bearing down and adequate contraction is present. Ma'am, eclampsia patient is ready for delivery. Yes, the patient is bearing down. Now we'll conduct a vaginal delivery. This is Radhika, please inform pediatrician.
Delivery will be conducted in the eclampsia room by the senior obstetrician as this bed is converted into the delivery table. The pediatrician is also informed.
1% of 10 ml lignocaine is given. Mediolateral episiotomy is given. बस आराम से बेटा. जोर लगाओ. बस हो जाएगा. Baby is delivered by cephalic presentation. ये देखिए कितना प्यारा बच्चा हुआ है आपका. For this time, sister ji, give her oxytocin 10 unit IM. Dr.
Oxytocin 10 units IM given.
Placenta is delivered by controlled contraction method. Dr. Tanya, check the vitals of the patient.
Ma'am, her BP is 130 by 90 and pulse rate is 92 beats per minute.
And on auscultation?
Ma'am, bilateral chest is clear and cardiovascular system seems to be normal.
Episode में side is sutured, uterus is well detected and bleeding is within normal limits. Dr. Tanya, how long will you continue the magnesium sulfate in this patient?
Ma'am, till 24 hours after delivery or the last seizure, whichever is later.
Okay, keep a check on vitals of the patient.
The patient is kept in the eclampsia room for further monitoring. Maintenance dose of magnesium sulfate and tablet labetalol 100 mg 8 hourly is continued.
देखो पूजा क्या हुआ है. हाँ हाँ पूजा लटकी हुई है. पूजा ठीक तो है ना.
Breastfeeding should be initiated within 2 hours of vaginal delivery or as soon as possible. After 48 hours.
देखिए भैया आपके मरीज को दौड़ाया था, ऐसे फिर से दौड़ाने का चांस होता है तो हम आपके मरीज को एक दिन और निगरानी में रखेंगे. कल छुट्टी करें.
After 72 hours.
देखिए आपका मरीज तो बीमार था, अभी तो उनसे खाना नहीं बनवाना है, उनको आराम दीजिए हफ्ते 2 हफ्ते तक. आज डिस्चार्ज कर देते हैं, अब मरीज को ले जाइए, लेकिन लोकल अस्पताल या कोई भी एएनएम या आशा वर्कर है उससे बीपी चेक कराते रहिए. और कभी भी सर दर्द हो या कुछ भी धुंधला दिखे तो हमारे पास ले आइए.
So a patient of eclampsia is well managed and is discharged in a healthy condition on postnatal day 3. No matter where a woman delivers, giving birth should be a moment of joy, not a sentence to death. Thank you.
The session will be chaired by Dr. Pramila Malik, Dr. Pushpa Dhaya, Dr. Anita Handa, and Dr. Vimla Dhaya.
थोड़ा बड़ा कर दो, बड़ा कर दो। हो गया बेटा? हाँ? इसको स्लाइड शो करना चाहते हैं।
हो गया, स्लाइड शो हो गया, आप इसको नेक्स्ट।
अच्छा ठीक है। शुरू करूं? तैयारी होगी तुम्हारी? हाँ? तुझे हम वो करने देंगे। मैं अच्छा ठीक है। तुम next करो। हाँ? Hello, good afternoon everyone. First of all, I would like to thank the Haryana Obs and Gynae team leader, Dr. Agni Agarwal and her team, as well as Dr. Ruby Bhatia and MMISR, who have given us the podium to be here. So the way it has been said previously that for respectful maternity care and we are dealing with the obstetrical emergencies, eclampsia drill has already been said and it has been shown, which was very good. And now the PGI Rohtak is going to show you the management of postpartum hemorrhage. So as we all know that no matter where a woman delivers, giving birth should be a moment of joy, not a sentence to death. Because we know that whether the patient is delivering in primary health center, CHC, or in a medical college or in a clinic, she should enjoy the pregnancy and the childhood. So with these words, I just want to say that every 7 minutes, a woman dies due to pregnancy or its related some complications. And this is one of the leading cause because hemorrhage, sepsis, toxemia, these are the leading causes of maternal death. And it was told in Parliament that maternal mortality has reduced a lot. But how much it has reduced? It is 97 per 100,000 live births. But it is still very high if we compare with the developing countries or some
parts of our own country where the maternal death is very low. So we need to find out that we have to reduce these from 97 to 70 per 100,000 live births. And for this, we all have to work together that at any time when the patient is coming to us at any facility, how we can reduce the incidence of postpartum hemorrhage by, you can say, we can find out high-risk mothers and we can refer them to a higher center if we feel that these high-risk mothers, they can have the postpartum hemorrhage or eclampsia. Next. As per WHO, there is a reduction in maternal mortality by 77% if we go by 1990 chart. Right now in 2020 it was 103, now it is 97, but our aim is that as per SDG goal, we have to reduce to 70 per 100,000 live births. So still the challenge is there for us to reduce it to 70. So we have to work hard for that. Next. So this is the pie chart which is showing that these are the worldwide the causes of maternal death, out of which the hemorrhage takes around 24% of the causes of maternal death when the PPH, either the antepartum hemorrhage or postpartum. Antepartum hemorrhage to a great extent we cannot prevent, but definitely the postpartum hemorrhage we can prevent it, and 24%. So PPH is a typical obstetrical emergency which that can develop rapidly and progressively, very fast, unexpectedly. So we have to be always prepared to deal with the postpartum hemorrhage, and in each and every labor room, the PPH tray has to be there. And the this is the most common cause. Now the students, they are going to show us that how the postpartum hemorrhage has to be managed.
So I am Dr. Pratima, will be the moderator for the PPH drill. Dr. Poonam will be the consultant. Dr. Monica will be the senior resident. Dr. Konika will be junior resident. Dr. Ravneet will be the nursing officer. Dr. Amanat will be the nursing, the attendant, and the patient would be Dr. Simran. Let's start with the drill now.
ज़्यादा नहीं सीगा 3.5 किलो सीगा इधर डॉक्टर साहब लिखे होएगा।
अच्छा ठीक है, मैं कागज देखती हूँ। पर आप ये बताओ कि औजार भी लगे थे?
नहीं डॉक्टर साहब कोई औजार नहीं लगे।
कोई औजार
नहीं डॉक्टर साहब।
और मरीज को कोई और खून बहने की बीमारी है?
नहीं डॉक्टर साहब,
कोई और खून की बीमारी?
नहीं डॉक्टर साहब, बस ये ना आयरन दी गोलियां नहीं खांदी सी, डॉक्टर ने दस्या सी दा खून घट है डॉक्टर साहब।
अच्छा, तो खून चढ़ाया है क्या उन्होंने कोई?
नहीं डॉक्टर साहब, उन्होंने कोई सीगा नहीं का खून।
ठीक है, तो हम अभी देख रहे हैं। आप अभी
डॉक्टर साहब प्लीज एकता नु बचा लो डॉक्टर साहब, छोटे-छोटे बच्चे ने दे डॉक्टर साहब।
हम पूरी कोशिश कर रहे हैं और मरीज को खून भी चढ़ाना पड़ेगा, तो आप खून का इंतजाम भी कर लीजिए। ठीक है
ठीक है।
Dr. Monica, this is the PPH patient. She is looking very pale. Dr. Monica, have you arranged for the blood?
Yes, ma'am.
her vitals?
Ma'am, right now her pulse is 104 per minute and BP is 104 by 60.
Madam ji, आराम नाल मैडम जी.
Ma'am, patient delivered 2 hours back at CH Jhajjar. She delivered a baby girl of 3.5 kg. There is no history of any instrumentation and there is no history of any other breathing disorder. She is referred here for atonic CPS and not a single bed has been conceived.
How have you managed the patient, Dr. Monica?
Ma'am, we
have
have
given
given
oxygen
oxygen by mask.
ठीक
We
हो
have
तो?
secured 2 alkaline cannula. On one we have started normal saline and another we have started on Synto. Ma'am, the patient is looking very pale, so we have arranged blood, ma'am. We have arranged 2 unit PCV, 2 unit FFP. Ma'am, we have started, ma'am, uterine massage via simultaneously and have catheterized the patient.
देखो बहन जी, एक बार नीचे से चेक कर रहे हैं.
मैडम जी, आराम नाल करना मैडम जी.
I have explored the uterine cavity. Uterine cavity is empty. There are no retained vesicle. Now I am starting with the bimanual massage.
मैडम जी बहुत पीड़ हो रही है मैडम जी, आराम नाल मैडम जी.
Uterus is still relaxed. Sister जी, Synto बढ़ा दीजिए. और कितनी डालूं? 40 units कर दीजिए please. Doctor done. Injection Trenexa दीजिए. 1 gram IV slow. Trenexa 1 gram. Sister जी, tablet Mesoprost दीजिए 800. Dr. Monica, पर rectally tablet Meso रखिए.
टैबलेट Mesoprost और you can press for it.
आराम से कोई दिक्कत हो रही है?
मैडम सांस लेने में दिक्कत हो रही है मैडम जी.
लंबे गहरी सांस लो.
Now I am continuing with the bimanual massage.
Monica, what are the repeat vitals of the patient?
Ma'am, patient की pulse 110 per minute and BP is ma'am 100 by 54 mmHg. Chest clear है, CO2 98% on 10 liters of oxygen.
मैडम जी दर्द हो रहा है मैडम जी.
After 15 minutes, uterus is still intermittently relaxing. Sister जी, injection carboprost load करिए. Dr. Monica, balloon tamponade prepare करिए फटाफट से. और patient के attendant को इसके बाद high risk consent भी explain करके आना है. Yes, ma'am. Patient is still pouring. Dr. carboprost 250 microgram iron start कीजिए.
कितनी टाइम नोट कर लीजिए. मैम 15 मिनट्स हो गए मैम. पेशेंट का यूट्रस इतनी इंटरमिटेंटली रिएक्ट कर रहा है मैम. सेकंड कार्बोप्रोस्ट लगवा दो मैम.
Sister जी, carboprost repeat कर दीजिए please. In the meantime, you will be demonstrating how to raise the balloon temperature. Dr. repeat carboprost is given.
For preparing the balloon tamponade, we are taking the Collis catheter, 1 condom.
देखो बहन जी.
मैडम जी पीड़ हो रही है मैडम जी. मैडम जी आराम से रहिए, आराम से.
No, we don't sterilize the condom. It is just taken like that only. So condom is placed over the balloon and it is just tied. The precaution has to be taken that it should not be very tight so as to just occlude, and saline cannot be passed, and it should not be loose so that the saline just leaks out. So we usually hang the drip and try to fill the saline till the balloon is visible at the os. So mostly it will.
So now this cell, you see. So you see, it will keep on increasing in the size, and after that, this is going to compress the bleeding side. So it has to be like this inside, and it will. And once the bleeding stops, to keep this in place, the vagina has to be packed with the roll gauze so that it remains in the place. So after this, but before putting this, we have to explore the cervix also and the vagina to exclude that there is no cervical tear, no vaginal tears are there. It is only the atonicity of the uterus. So by this, along with it, because once we have given the all oxytocin drugs, after that we put it.
बताना है
Then we can keep it for 12 to 24 hours, and whenever we have to start deflating, gradually we have to reduce the volume of the balloon, the saline. So that, and in between we have to monitor the patient, and at any time if we feel that the bleeding has started again, we may have to stop deflating. That means still we have to keep the balloon inside, and the broad spectrum antibiotics are to be given when we are putting the balloon catheter. Cervical.
There is another technique of Chhattisgarh balloon tamponade. So here blood, there is a return system also. So if there is a drainage system also, so if there is any blood which is accumulating, it will just come out because the anterior end is being cut open. So it comes out. So this is, we can say, a better this thing, because many times the blood will just get collected inside. So with this type of technique, the blood, that collected blood will come out and help in further. So the advantages are that it is simple and people can do, and I will really tell you that we are using it so frequently these days, even prophylactically many times we are using. Like many patients, all of you will agree that people with thrombocytopenia, all of us will agree somehow we don't know why thrombocytopenia has increased. So many times we put a preventive balloon tamponade also. So it controls uterine bleeding. Mostly we have seen it's very effective, and it can be used in very simple, can be used in low resource settings, and especially in transit also it can be.
Let me explain high risk concern and procedure to the patient. We might have to take the patient to the OT. जी डॉक्टर साहब हाँ जी मैंने जैसे कि आपको बताया कि आपके मरीज़ का डिलीवरी के बाद बहुत ज़्यादा खून बह रहा है। हमने अपनी तरफ से पूरी कोशिश करी है कि हम दवाइयों से खून को कंट्रोल करने की कोशिश करें। अगर हम तब भी जो है कंट्रोल नहीं कर पाए तो हमें मरीज़ को ओटी लेके जाना पड़ रहा है, ऑपरेशन थिएटर। क्योंकि मरीज का अगर दवाइयों से खून कंट्रोल नहीं होता है तो फिर हम ऑपरेशन थिएटर में जाके खून कंट्रोल करने की कोशिश करते हैं, जिसके और भी तरीके होते हैं। अगर तब भी खून कंट्रोल नहीं हुआ तो हमें मरीज की बच्चेदानी भी बाहर निकालनी पड़ सकती है।
नहीं डॉक्टर साहब, हले सानू होर भी बच्चे चाहिए ने, बच्चेदानी ना कटियो डॉक्टर साहब।
मैं आपकी बात समझ रही हूँ कि मरीज का पहला बच्चा है, पर आप ये समझिए कि मरीज की जान बचाने के लिए आखिरी स्टेप हमें लेना पड़ेगा। हम अपनी पूरी कोशिश करेंगे बचाने की, पर अगर कंट्रोल
एक तानू बचा लो डॉक्टर साहब, जिवें मर्जी बचा लो।
हाँ, ये आप आपके इनके मरीज के हस्बैंड को भी बता दीजिए, कंसेंट पे साइन करवाना
ठीक है डॉक्टर
आप उनको, और हमें मरीज को बहुत ज़्यादा खून चढ़ाना पड़ेगा।
Now, as the vitals of the patient are deteriorating, we are taking the patient for laparotomy, and we have taken the high-risk consent for hysterectomy from the families, from the patient's family. Shifted to the operation.
So under these conditions, we have shifted the patient to OT. We might have to do a laparotomy. So what are the different mechanical methods? We have already tried balloon bimanual compression, and uterine packing, which has been done by a tamponade, has already been done. So now after laparotomy, we have other techniques. We can do brace sutures, or we can do ligations of the vessels. So brace sutures. So let me explain about the B-linge first. B-linge first. So how the suture is to be taken, starting from the lower end. Just show. We are supposed to take from the lower end. This is, and starting from here, we will take the suture up, go behind. From the behind, again we are going to take the stitch outside, again back, take this loop, and after this loop, then we have to push so that once the stitch has been taken, so this way we have to contract so that the uterus is completely squeezed. And then we have to, this suture material which we are using is the catgut one. Okay, so it's going to be very effective, and when we are squeezing it, the bleeding stops. That means it's a very effective one. So the other suture is, this is the B-linge one. Let's say if it is the cesarean has not been done, then in those cases this Hayman suture can be taken. So rather it is a very simple one. We just take from the lower end and tie at the upper. So usually the 2 stitches are enough, but if required, then maybe we can take the 3 sutures also. So when we are tying also, it has to be squeezed so that the maximum compression can be done. This is about the Hayman. Another part is, like if still the bleeding is there, the other is the chocho sutures. So these are the chocho sutures which can be taken, and like this you take it and make it a knot. So at multiple levels you can put these chocho sutures to, these all are done to save the uterus. Wherever the bleeding is there, multiple these sutures can be given. After this, still if something is there, the patient is bleeding, then we can, the compression sutures are not, then we can go with the devascularization. Dr. Meenakshi is going to show us.
So we can do a stepwise devascularization. In the beginning also you can do, or maybe for this, or both the things can be done. Okay, so the principle of this stepwise ligation method is progressive devascularization. So each step is performed, and the next step will be performed only if the bleeding has not stopped. It's not that you have to do all the steps. So what are the steps that you, first of all, you do in unilateral ligation of the ascending branch of the uterine artery, then the contralateral branch, similarly then lower ligation of both uterine arteries and cervicovaginal branch of uterine, and same then done on the other side, and then the ligation of the ovarian artery near the ovarian pedicle. So these is next. So for that, a ligation of the uterine artery at the level where it runs along the upper uterine border, beside the upper part of the lower uterine segment, the site of ligation, lateral border of the uterus,
it should include at least 2 centimeters of the myometrium. So that is important. And suture material used is chromic gadgar. We will not use Vicryl in these cases. And so on one side this is done. Similarly, it is done on the other side if bleeding has not stopped. So these are the sites. Then we can do the low bilateral uterine vessel ligation, the site of ligation as the lower part of the lower uterine segment, 3 to 5 centimeters below the upper ligature. Again, the suture material is the same. And if bleeding not stopped, same thing, same procedure can be done on the contralateral side. Then we can also use uterovarian ligation of the vessels, the uterovarian anastomosis. It is just below the point where ovarian suspensory ligament joins the uterus. And same thing can be done on the other side. So these are the different ligation. And even then, if we think that the bleeding has not adequately stopped, then we can do an internal ligation of the anterior division of the internal iliac artery. So it turns the pelvic circulation like a venous system. And it's very effective in uterine atony and other hemorrhagic conditions also. So here, just to identify, it is very easy. We are not supposed to trace the posterior branch. We can just from the around 3.5 to 4 centimeter below the division, if we ligate the internal iliac, that means the posterior branch has already left the place and we are ligating the anterior. But still, you can palpate the femorals and the popliteal so that we don't ligate the posterior division. That is important. And pass the clamp from lateral to medial side. This is the important thing, and just pass the suture. But one more important thing is that even if while doing these steps, you think that the patient is deteriorating, bleeding is very high, then we have to resort to hysterectomy also. Though we want to save the uterus, but we just don't want to lose the patient also. So that we have to just keep on seeing the vitals and everything. Thank you. Ascending branch need not push the bladder down, but when we are ligating the lower revision and the cervicovaginal, then better if it is a vaginal delivery, open the UV pouch and push the bladder down and then take the bladder.
Excellent drill, Dr. Meenakshi and Dr. Pushpa. Just
sorry, Hanji. Hanji. Also. And when the bleeding stops, which means okay. So when the bleeding, because you see, when we are putting the balloon, we are inflating. For how much volume we are putting? Usually 300, 350, and by the time this balloon, that condom, that is visible at the cervical os. It means the whole uterine cavity has been filled, and that's why it has. After that, we push so that we want to keep this balloon in place, we are putting this gauze vaginal pack to keep in place. And usually 12 to 24 hours we are keeping. By this time, we are starting with the oxytocin drug so that uterus contracts. And the bleeding. After 12 hours, we give broad spectrum antibiotics also because it's a foreign body we are putting inside. And we monitor the patients in the close monitoring is to be done in our intensive care unit only. And then after 12 hours, we start deflating it. Oxytocins are going on. The blood and blood products, whatever is being required, we just transfuse, replace the volume also. And then gradually we reduce. Let's say it's a 350 ml is there. We are going to reduce the 100 ml first. See, look for the vitals. If everything is fine, no bleeding is there, then we just deflate it further. If we find we have to prepare ourselves that in case it starts bleeding, then we may have to inflate it further. Okay. But definitely we have to continue. Anything else?
Excellent drill, Dr. Meenakshi and Dr. Pushpa. Just few comments. One is we have got PPH cannulas also, Samarthan's cannula. I personally used it. That's also very effective. And secondly, carbetocin. What is your experience with carbetocin? Because I have been using carbetocin and it's much better than oxytocin. It's very good.
Actually, carbetocin, according to FDA, we can't say because it is used for, it has been approved for prophylactic purpose only. That is why we just can't say that it we can use
instead
it.
of oxytocin, when we are giving oxytocin,
No, you are right.
carbetocin,
It is effective also.
It gives a permanent retraction of the uterus.
But we can't, I mean, it's not evidence based for therapeutic purposes. It has not been approved by the FDA. As of now, it has been approved only for prophylactic purpose. So it can be very good if we have given it already for prophylaxis. Maybe she might not had that PPH.
Thirdly, when we are transferring the patient from the referral to the referral center, or we are shifting the patient to OT, the role of NASG garment, non-pneumatic anti-shock garment, to maintain the vitals of the patient.
If you are having that garment, you can just use it and transfer. But most of the time, it is not there. And as far as the carbetocin, definitely till now, it is for the preventive measures. The role is not there, but definitely, the way you said, it's going to contract the uterus, like you can say the technique contractions is going to be there for 120 minutes.
Yes.
If you give one injection, it is going to be prolonged.
My personal experience is very good.
But definitely, and
For
about
both,
your
even
cannula, about cannula also, yes, definitely it reduces the amount. They say even for prophylactic in a routine, some people they are using it. Not here. In routine also they are using this cannula, so that immediately after the placenta is being delivered, they put the cannula and attach to the suction one. And they say that immediately the cavity collapses and
The sinuses
squeezes on.
just
Sinuses
close.
get closed
Yes.
also. Vacuum.
How do you assess, sorry I came a little late, okay, now it's completely ballooned out and now to stop
Once the bleeding stops and that balloon, condom balloon is visible at the os, cervical os. After that we don't.
That means now it was completely occupied the uterine
Pulling.
Not pulling it, simply we let the saline go inside and gradually it will fill and the os is open. So when we see the balloon at the os, there is resistance, no further. See the amount of saline which has gone.
And practically how much balloon saline goes in?
300 to 350. Very commonly in our labor room we are using, because when the referral patients they are coming, and rather prophylactically also in case of placenta previa, wherever we feel that lower segment is may bleed and the sinuses are open, we also put it for some time.
I also want to tell this Chow's suture, the square shaped suture, they are very effective in placenta previa.
Yeah, just
They are only localized just in the lower.
the lower segment we can. Balloon. But I think we have not explained about the how to prepare the Chhattisgarh balloon.
At that time constraint, there are many
Yeah.
things which could have been done. one. It is miraculous. Internal leg, I have my own experience, miraculous. We were like in a soup, but as soon as we ligated the internal
Especially in broad ligament hematomas.
Yeah.
In broad ligament hematomas, it's the only treatment.
We are getting referred cases.
Yes.
It was already in DIC. आपने hysterectomy भी कर दी, but वो bleeding रुक ही नहीं रही है, and then this internal ligation. That magic.
Sterilization of condom is not required.
No, it's not.
You can keep it in some formalin chamber or. Because
breakage. Thank you so much for a good interaction.
That was an incredibly informative session on managing one of the most common cause of maternal mortality worldwide.
Attention everyone. Now we have a discussion on maternal collapse, a rare but serious condition. I am delighted to invite Dr. Richa Kansal and her team from Kalpana Chawla Medical College, Karnal to enlighten us with their profound insights. The session will be chaired by Dr. Rahul Joshi, Dr. Anjali Sharma and Dr. Meenakshi Chauhan.
Good afternoon, everyone. Richa ma'am is not able to join today because of some family commitments. So I, Dr. Isha Bansal and Dr. Priyanka will be talking about maternal collapse. So as you all know, maternal collapse is an acute event caused by cardiovascular, respiratory or CNS failure occurring at any stage during pregnancy and up to 6 weeks postpartum, resulting in absent or reduced conscious level. So it can lead to cardiac arrest and death. So prompt identification and timely intervention is required by a multidisciplinary team, which includes an obstetrician, the staff, and an anesthetist with an ICU care, so that the maternal as well as the fetal outcome can be improved. Accurate rates of maternal collapse are unknown because overlapping causes are there. So severe maternal morbidity, cardiac arrest in pregnancy, even maternal death rates define its incidence. It is an important cause of cardiac arrest. All over the world, various studies are being done to show what is the rate of cardiac maternal collapse, but exact number is still unknown because of the overlapping causes. So before understanding what is maternal collapse, we need to remember what are the various changes which occur during pregnancy, which lead to changes in the collapse. So as a healthcare professionals, in resuscitating any pregnant patient, you need to be aware of various systemic changes which occur during the pregnancy. So as you see, everybody knows about the basic anatomy and the physiological changes which happen during the pregnancy. There is increase in the plasma volume, increase in the heart rate and the cardiac output, leading to dilutional anemia and increasing the circulatory demand, and the chances of the CPR demand increases during the pregnancy. Similarly, there is uterine pressure over the various vessels, major blood vessels, leading to supine hypotension. And that also affects the perfusion of the various organs. Similarly, talking about the systemic vascular resistance, which is decreased, the arterial blood pressure decreases, leading to decrease in the reserve in the female patient. Talking about the respiratory rate, which is increased, decreases the buffering capacity of the patient, leading to more chances of acidosis. Laryngeal edema is increased, which makes the difficult intubation. So as we see, when the patient collapses, and we try to intubate, the intubation is difficult in such patients, which changes the CPR in a non-pregnant patient and a pregnant patient different. Gastric motility is decreased, the lower esophageal sphincter is relaxed, causes the chances of aspiration more. So, talking about the causes which can cause maternal collapse in a female patient, there are various causes of maternal collapse which can be remembered as 4 H's and 4 T's. The 4 H's include hypoxia because of either pulmonary embolism, failed intubation or aspiration. As we talked, our chances are higher in a pregnant patient. Heart failure, anaphylactic shock, eclampsia or preeclampsia is a very important cause of maternal collapse. Intracranial hemorrhage, and obviously COVID-19 pneumonia, everybody knows that it has been an important cause of maternal deaths. Hypovolemia is the second H, another important cause, as discussed earlier. Hypovolemia, cause of hemorrhage, either acute or chronic hemorrhage, and massive obstetric hemorrhage can lead to maternal collapse suddenly. Sepsis, anaphylaxis because of some drugs like local anesthetic or magnesium toxicity, high regional anesthesia. Other causes are hypothermia or electrolyte imbalance like hypokalemia or hyponatremia. The 4 T's include thrombosis because of amniotic fluid embolism, pulmonary embolism, air embolus or MI, toxins like similarly I talked about local anesthetic toxicity, magnesium toxicity, opioids or some drug used by the patient. Then tamponade because of some trauma in some roadside accident, etc., aortic dissection or tension pneumothorax. So as you see, the causes जो हम वैसे हम बात करते हैं like eclampsia and PPH, these are the causes only which will lead to maternal collapse in the patient. So it can result from causes which may or may not be pregnancy related. So a systematic approach to assessment will facilitate the identification of the cause. And obviously if the cause is reversible, the patient can be saved, making the maternal outcome favorable. Now, an important thing to remember is use of the early warning scores to identify maternal collapse. Can we see if patient can go into maternal collapse? Can we identify these patients earlier? Obviously, to identify early recognition and interventions in such patient, modified obstetric early warning score or a MEOS system has been made, and it can be used taking into account all the physiological changes for all the obstetric patients. There are other scores available which have not been adapted according to the pregnancy. So this has been adapted according to the pregnancy, the MEOS score. So MEOS score, it includes all the vital parameters, that is the temperature, the systolic blood pressure, diastolic blood pressure, heart rate, respiratory rate, and the neurological response of the patient. And then the scoring is done from 0, 1, 2 or 3 on the both sides of the normal. So 0 is normal. On the both sides, 1, 2 and 3, more of the red alerts, 2 or more red alerts will obviously initiate a higher response. So the more care is required in such patients. If the yellow alert is seen, either the score is 1 or in between the 2s, then if the yellow alerts are there, then you need to take care. The patient may get unwell. So taking into care that these scoring systems can help in preventing maternal collapse or preventing a untoward significance. So clinicians should be aware that maternal collapse may occur without any warning and with a normal MEOS also. So your clinical acumen will be very helpful in such states. So Dr. Priyanka will be talking about the resuscitation and management now.
Today we will discuss very important event in obstetrics, which is a nightmare for all the obstetricians. But friends, it is important to prepare and learn how to respond to maternal collapse emergency. The first important step is to call for help and approach the patient safely. And by this I mean that ensure you are in a safe environment and the patient is safe and you can call all the medical personnel available around. The next step would be your approach towards the patient. Now check the responsiveness by talking and tapping the patient gently. And very important step during this maternal resuscitation is to relieve the pressure on IVC, and for that you can apply a tilt towards the left by using a Cardiff wedge or by manual uterine displacement towards left side. If you find that the patient is responsive, place her on her side and continue the assessment. But if she is unresponsive, check that the help is on way. You alert the maternal code blue, and first step would be to maintain an open airway that can be achieved by either suctioning or by using a triple maneuver, which is head tilt, chin lift, and jaw thrust. Now check the breathing of the patient simultaneously by looking to it, looking for the chest movements, listening to the breath sounds, and by feeling them. Now this assessment should not take more than 10 seconds in this position. If the patient is breathing, place her on her side and continue to assess. But if she's not breathing, you must commence for CPR without wasting any time. And in maternal CPR, you give 30 chest compressions, not exceeding more than 120 per minute, and then 2 ventilations are given. The depth of the compression may be compressing the center of the chest by 5 to 6 centimeters, and then we repeat it in the ratio of 30:2 and continue it till the help arrives and ACLS can be started. Once the patient is intubated, the ventilations may be like 10 breaths, but continuous chest compressions are administered up to a rate of 100 to 120 per minute. In maternal resuscitation, it is very important to make arrangement for emergency cesarean section, or which we commonly know as perimortem cesarean, and it is aimed to that the baby be delivered within 5 minutes of maternal collapse if there is no response to CPR and the gestational age is more than 20 weeks. It is important to know that perimortem cesarean is done solely for the benefit of mother and not for the baby. It is done primarily at the site of resuscitation using only a scalpel and 2 cord clamps. It's because perimortem cesarean decreases the uterine compression on IVC and thus facilitates or improves the venous return, resulting in improved maternal cardiac filling pressure. Meanwhile, you must ensure that the neonatal team receives the newborn. Now we can continue the ACLS high quality CPR and use defibrillation when indicated. The same defibrillation settings are used as in non-pregnant patient, using 150 to 360 joules if it is biphasic or 360 joules if it is monophasic. When you use the 2 pedals, the left defibrillator pad should be applied below and lateral to the left breast, like this, and the right one can be placed as we place in the non-pregnant patient. If the rhythm which comes on this defibrillator is non-shockable, continue with the CPR, and if it is a shockable rhythm like ventricular fibrillation or pulseless ventricular tachycardia, then first clear, give 1 shock followed by CPR for next 2 minutes, and remove the CTG monitor before you deliver the shock. Use other ACLS interventions like adrenaline, which may be administered in the doses of 0.01 milligrams per kg every 3 to 5 minutes by the staff present there in the team. And consider the etiology of cardiac arrest, which my colleague has already discussed earlier, including the 4H and the 4Ts. If the patient has been receiving IV magnesium sulfate, we must stop it and give calcium gluconate. Since we were not sure whether we would be provided a mannequin for this drill, we will present to you a recorded drill.
cord blue. Starting CPCR. 1.
There is some sound issue, so I'll try to still explain it. The staff nurse on her general round after doing ARM in a patient of 30 weeks pregnancy suddenly notices that the patient is not responding to her commands. So the assistant is coming and tapping the patient, tilting the head to one side and checking for the carotid pulse. Now, since they were able to make out that the patient is not breathing and she's pulseless, so breathing is absent, pulse is absent, so they immediately alerted code blue. Meanwhile, the staff which was present there, once they have called the doctors, they started the CPR. The CPR has to be performed in a very comfortable environment or wherever the patient has collapsed, but make sure the person who has to give CPR should be able to give effective chest compressions, like keeping one hand over the other, and should be able to depress the sternum by 5 to 6 centimeters at least. And then there has to be switch over of the roles because one person cannot give this much thrust for a continued long duration. And once we talk about the lateral tilt of the uterus, either a Cardiff wedge can be used, or in the hospitals generally we find the bolsters which are available, which may be placed under the buttocks of the patient to tilt the uterus to the side. So eventually the idea should be that the uterus should be displaced at least by 1/2 or 2 inches from the midline. Now this will reduce the aortocaval compression and will improve the cardiac output and venous return by 30 to 40%, and eventually this helps with the resuscitation. Now here we can see that the steam is still, now a complete team has arrived once the code blue was declared, and there is one team coordinator who is giving instructions to everybody, and he will define the roles of everyone so that we do not create any panic. And it is a closed communication loop. Now this team leader is defining the role. The uterus, you can see, has been tilted to one side manually, and the chest compressions are being effectively administered. And after every one round of CPR, they are continuously reassessing the pulse and checking for breathing. After maternal CPR of 4 minutes, the decision for perimortem cesarean has been taken up in this case. And the cesarean, this perimortem CS, can be performed Once the gestational age is more than 20 weeks of gestation, you can call for a neonatal resuscitation team, and it is performed using minimal instruments, giving a midline incision and opening the uterus also by a midline incision. Leaving the placenta in situ, one must pack the uterus, and because the field will be bloodless since the patient does not have any circulation, and rest of the procedure will be completed inside the operation theater. After delivering or performing this perimortem cesarean, the team is again reassessing, and they found out, the team found that there is a return in the pulse. They could feel that the patient is started breathing again. So the team coordinator ordered for intubation of the patient, and then they shifted this patient to operation theater, and after that, ICU. Now, after shifting the patient to operation theater, closure of the uterine incision, placental delivery, and rest of the things can be carried out. Yes, our team would be available. We would be there to assist.
So perimortem cesarean section is an important thing which you need to know. A good leadership, closed loop communication, and task allocation is of paramount importance while dealing with maternal collapse. So concluding, maternal collapse, although rare, may be caused by a wide variety of pathologies. A multidisciplinary intervention is required in all unstable pregnant patients to prevent cardiac arrest. Emphasis is on effective cardiopulmonary resuscitation, uterine displacement, early intubation and resuscitative measures, and going for perimortem cesarean section if the CPR, after the 4 minutes of CPR, the patient is not responding. ECMO can be considered in a critically ill patient who has responded and has been seen. And obviously, all these measures will improve both the maternal and the fetal outcome. Thank you so much. Any questions? Consent.
All smart people who deal with such situations. So one of them is allocated the role of taking the consent and debriefing about the situation, which goes simultaneously. So instead of the person who is performing CPR and other people taking the stress, it is an entire team effort. Another important thing would be about the role of perimortem cesarean. If it is not done timely, then there is no use. So even if we do get calls in our ICU also that the pregnant patient which we had induced for labor because she had an IUD suddenly collapses. So whenever we get a call from the interventionalist, it is the consultant on call who immediately reaches, and we see that a CPR is going on. With the minimal instruments, just with gloves in the hand, we open up the patient, deliver the baby, pack the uterus, ship the patient to OT for further procedure. Yes, irrespective, because it is solely being done only for maternal interest to reduce or improve the chances of CPR. Yes. Thank you so much. Yes. Yes, we do get. We have. Yes, yes. Within 4 minutes of maternal collapse, if it is performed, then we definitely have chances of maternal survival. And I myself got the opportunity to do this when I was quite young. Same place, ma'am, without wasting any time. This has to be done very, very meticulously with a very good obstetrician. Yes, nothing. Just simple gloves. You need not paint, drape, wash. Just a simple betadine swab. Rub it, give a midline incision, perform a classical cesarean, and deliver the baby. That's it. There is other person allocated to take consents. I cannot take stress about that. It is a complete team. Maternal resuscitation team is a new concept which has come up. Generally, it is the call of obstetrician who decides whether... Yes, we are safe because it is solely done in interest of mother. We do have to tell, but about perimortem, I'm very sure that it is totally upon the doctor. If she thinks it is something to save the mother, we can. Yes, we do we can.
Excuse me, Dr. Rahul here. In ACLS situations, if we are doing CPR or following ACLS guidelines, you need not to take a written consent. You can explain them, and after that you can take a written consent. But in ACLS guidelines, you need not to take any consent.
Yes, ma'am.
You have to save the patient.
Generally, we start with this work and we order one of our senior residents or a junior consultant who keeps the relatives satisfied. And there have been situations when I have done such cases right in the labor room when the patient collapses. And then we later on shift the patient to SICU.
Obviously, it will depend where the patient collapses. If the patient is received late in your labor room, then obviously your resuscitative efforts will not be of much use.
So the entire team makes an effort that you clear off all the patients around, contain the patient in a safe environment, apply curtains or something, call the resuscitative team. So you must have a maternal resuscitation team in your hospital. Once you don't have, the hospital resuscitation team can be allocated this task where you add an senior obstetrician also in that. What was your case? Can you summarize it? Ma'am, it was the case which was... It was a 30 weeks pregnancy only, ma'am. After doing an amniotic fluid ARM, she suddenly stopped responding. Embolism only. So we, instead on that labor bed only, we had to perform all this. The patient was saved. Patient was saved. So I just alerted one of my colleagues. A senior nursing officer was there on call that day with me. So I asked her to call my HOD and call the necessary people. So she made all the arrangements while I switched over to CPR, and I called my intensivist also.
Thank you, ma'am, for sharing your expertise.
Now we transition into more futuristic topic of robotics in obstetrics, illustrated by Dr. Girija Shankar Mohanty from PGI MER Chandigarh, expanding the existence of robotics in obstetrics.
The session will be chaired by Dr. Monit Walia, Dr. Rupa, and Dr. Rajni Bhatia. We shall move to the other hall for the robotics.
ऑन कैसे आवाज
Sorry, there is some change in plan. As the video, you need to change the format. Will take some time. So we'll continue the robotic surgery session after this session.
A very good afternoon, everyone. Thanks for showing patience in a great afternoon and having such a concentrated academic sessions. So I'm going to present the topic allocated, which is practicing endosuturing and ergonomics, and I think it makes sense before going for robotic surgeries to have a outlook of laparoscopic surgeries as far as endosuturing and these aspects are concerned. So I'll be covering these few sub-segments in this, where it is required, what all instruments are required, what are the suturing techniques, and how to maintain the ideal settings. So for all practical purposes, in gynecology, if we specifically talk about, then we deal with reconstruction part, suspension part, hemostasis part, and fixation part, in which the endosuturing plays a vital role. So laparoscopic suturing can be divided into three major categories. This phenomenon, say. So one is what all instruments we are going to use, what is the technique exactly, and what about the ergonomics, why it is such a big deal. So just a broad overview that there are two types of laparoscopic suturing. One is extracorporeal. It means everything is assembled outside and secured inside. And second one is intracorporeal suturing, in which the whole process is done inside. So the difference is, in extracorporeal suturing, the thread is brought out after taking the bite, knot is secured outside the abdomen, knot is secured outside the abdomen, and it is pushed inside at the surgical site. So this is the major difference between extracorporeal and intracorporeal suturing. So more or less all the instruments are the same in both categories, apart from a knot pusher which is required in extracorporeal suturing. So knot, since we know that knot is secured outside, it need to be pushed inside to the surgical, for which the knot pusher is required. So the technique per se can be, for the understanding sake, can be divided into two subgroups. One is how to introduce that needle and thread inside the abdomen. Second is how to load that needle on the instrument, because there are no hands, there is a tip of the instrument which is inside the abdomen which we are seeing. And third is how to maneuver that needle and thread complex, and finally how to secure the knot. So I'll be categorizing this technique per se into these four sub-segments. So first of all, how to introduce that needle and suture material in the abdomen. So the commonest ways, you hold the thread with the needle, the complex to be introduced inside the 10 to 12 millimeter trocar, which is the optic trocar. Or you can use the trocar on the accessory port side. You hold the thread along with the needle, it goes inside, and you are placed, the needle and the thread complex is placed at the surgical site. Second is how to introduce it through the 5 millimeter trocar. So this technique is called as back-loading techniques. So in which the thread and the needle complex is already held through the instrument, and it is pulled inside the 5 mm trocar, and short of needle, that thread complex is held, and with the needle it is introduced inside. And this way, the whole complex goes inside, and we need not dismantle this assembly of trocar and the needle holder or maybe the accessory instrument. Another way is, in one of the instruments, you traverse this instrument through another trocar, bring it outside the abdomen, hold the thread complex from there, and bring it inside. So we'll see here. From my right hand, I'm introducing a needle holder into the accessory trocar, and there I'm holding the thread complex and I'm bringing it inside the abdomen. This is one of the ways. And another way is direct entry through the anterior abdominal wall. Whenever we are using straight needles, which is very rare in gynecological cases, it can be directly introduced through the anterior abdominal wall, and it can be held inside the abdomen. So that is all about how to introduce that needle inside. Before going ahead and knowing how to hold that needle, how to manipulate it, we need to understand a couple of fundamentals in the manufacturing and the style of the needle which we are using, which is most of the time half circle needle we are using. So the needle per se has 3 equilibrium points. One is in the middle, one is towards the thread, which is point C, and roughly speaking, it demarcates the 2/3 and 1/3 of the needle circumference. Another point is point B, which is hypothetically speaking a junction between first third and the middle third of the needle. And the needle end where the thread starts is called as swage. So there is a point A also, which is approximately 2 to 3 centimeters from the swage. The end of the needle from where the thread is arising is also a point A, where you commonly hold the thread. We don't commonly hold needle per se with the instruments. So just to simplify it, if we take a midline from the needle, then left side means pointing side is handled by the left hand, and the right side, which is towards the thread side, is handled by the right hand. So how to load the needle on the needle holder? So now imagine we have taken the thread, we have introduced it through the trocars inside the abdomen. Now we are seeing the thread which is lying inside the abdomen at the surgical site. Now how to go about it? So the option 1 is you orient that whole complex, then align it, then write it, and then confirm it. So I'll explain how. So orientate means in which direction I'm going to take the bite. So most of the times the bite goes from right to left, because most of us are right-handed surgeons. So you need to align the thread in such a way that the point ends towards the left and the thread swage and goes to the right side. Then align it. Align it means you hold it in a needle holder in such a way that it is making an angle with the tissue site or the bite site where it is making a particular angle. We'll be discussing that later on in the presentation. And we are able to take a bite. And the last one is, once you have fixed the position, then you hold the needle holder and write it. You align it and write it. So once you fix it, then you confirm it. You hold with the needle holder, then lock it to the extent that its position doesn't change. So now this is that process exactly. You held the needle from your left hand, then from the right hand you fixed it and then took the bite. Now another method is just a variation of holding the thread and needle complex, in which there is orientation first of all, then writing it, then aligning it, and then confirming it. So how it goes? You orientate it as before, then you write it. Straight away you hold it at point C and just hold it with the needle holder. And then by maneuvering the thread end with your left hand, you align it in a plane in which you are going to take the bite. And finally, you confirm it, you lock the needle holder, and then go ahead. So for example, in this case, so I'm changing the direction of my needle and then fixed it and then took the bite. So how to hold, how to load, how to further maneuver it? So further maneuvering can be accomplished by 2 methods, holding from the thread or laying on the tissue. So now this point is particularly, you have taken a bite, you have taken out the needle, now how to go further? So this, one of the point is that you hold the thread from your left hand, and write your position from your needle holder from your right hand. And another way is you keep it on a surface which can be pressed upon. Press on the circumference in the middle, then the needle will align itself. See how it goes. The needle is lying on the tissue. You simply press with the needle holder and it will take its natural curve. And it will be in a position when you can take the bite. So how to rotate this needle on the needle holder? Because obviously you need a maneuvering, because suppose you are going in a continuous suture, then you want to go back, then obviously the needle direction changes. So there are two maneuvers with which it can be changed. So one is called as Watti's technique or grinding coffee maneuver. So this is how it goes. You hold the needle from your right hand, and then maneuver the thread so that the direction of the needle changes from the left hand, and then take a bite. And one of them is flag maneuver, in which your left hand holds the pointed side of the needle, and from the right hand, you change the direction and the axis of the needle, like this. So with all this, some sort of physics is going in the backdrop, which looks like it's very troublesome, but it is very mandatory to understand it. So the endo-suturing follows the theory of parallel axis. So what it means is, there is a wound which need to be sutured, and there is the needle holder which is holding the needle. So both of them should be parallel to each other. The axis and the needle holder, or the axis on which the needle is going to rotate, should be parallel. And this is called as angle beta. And this should be 0 degree between these two axes. So this is the wound axis, and this is the instrument axis or handle axis, you can say. So these should be at 0 degree. Whenever we are holding the needle on the needle holder, then these two axes should be at 90 degree angles. And this particular angle is called as angle alpha, which is 90 degrees. Needle holder and needle, 90 degrees. The same principle follows in open surgeries as well. So if we take the bite, then obviously this angle need to be understood, because from one edge we are taking a bite and we are taking out from the other edge. So that should also be at the 90 degree angle. So this yellow plane should be at the 90 degrees angle. So this angle should be 90 degrees. So this is called as angle gamma, which is the plane between wound medial virtual axis and the needle plane in which the needle is going to travel. So just to sum up, there is a needle holder and the suture. Then we pass this whole complex inside the abdomen, and then we knew how to hold that needle on the needle holder. Then we took a bite. Then we need to suture it. So this is the point where the differentiation starts, whether we are going to do it extracorporeally or we are going to create it intracorporeally. So first of all, extracorporeal. So there are various knots which are being prescribed in the literature, and various indications in which it is going to be used. And these are the types of knot pushers which are being used practically in laparoscopic surgeries. So this is the whole a pictograph which shows that the needle end comes out. We have put the whole needle suture complex inside, but we are keeping the loose end of the thread outside the abdomen. Then it takes the bite, and the whole thread and needle complex comes out, and that complex creates a knot, and that knot is pushed at the surgical site. And this is the point where the knot pusher plays an important role. So these are various types of knots: Rhodes knot, Melzer knots, Tay-side knots, Duncan, etc., etc. So the difference only is that on which limb you rotate the thread, or you wrap around the thread, and the final loop goes around both threads or the single thread. So these are the major differences. And the first throw, the first knot, for example, here is the Melzer knot is the first throw. First, the number of knots which are being thrown, for example, this is in 3. So this makes also a difference in which you say that these are different type of knots. So this is how it goes. So this is just to show that how to create that knot. So you put a loop around, you have taken a bite, then you've taken the thread outside, then you wrap around the longer limb once, then twice, from below upwards. From below upwards. So 1, 2, and this is the final throw. You got it outside, and then lock it. So this locking can be done with one of the threads. So this is how it goes. So this is the practical demonstration how it goes. So you have introduced the needle part inside. Remember, the thread is outside the abdomen. We have taken a bite here, and after holding the needle, once the bite is done, the needle is taken out of the abdominal wall, So here the needle has been straightened just to bring it out of the 5mm telescope, 5mm trocar. So now this is how it is being brought out, and the knot per se is configured outside the trocar. So outside the trocar, once we configure the knot, then we use the knot pusher and push or slide this knot through that trocar inside till the position of the suture side. So this is how extracorporeal knotting is done. So when we come to intracorporeal knotting, so intracorporeal knotting basically is how to prepare a knot, how to throw a knot, and how to secure a knot. So preparing is just commonly understood that we have taken a bite and we are just segregating the distal end and the proximal end of the thread. Then we make some throws, and then knotting is merely pulling up of the two threads. So there are a couple of techniques in which one of them is smiley technique. So the smiley technique is said because the needle holder holds the pointed end of the needle just to make the C visible in front of you, going from right to left, so that this metallic end of the swage end of the needle plays as a lever to throw the knot around your accessory trocar. Another one is expert technique, in which the right hand holds the thread itself, not the needle, and it makes round movements around your left hand, configures the knots, and then tighten it. Simple. The last technique is the cinch technique, in which two consecutive knots are thrown simultaneously. So it all looks pretty simple, right? So after understanding all these things, it's a very common phenomena. We say, okay, I know the thing, I have practiced, everything fine, so pretty good. So this is what happens. So can I ask one question, that who among the audience has noticed that how many sutures were there on the left side of the picture? Has anyone noticed? So that is the reason we are distracted. We think that task is accomplished once the surgery we are supposed to do. Suppose we are doing TLH, uterus is removed, job is done. But that part is still remaining. The endosuturing part is still remaining, which is very crucial for understanding all these things. So let's go with this video. Open hysterectomy, taking clamps, taking suture, transfixation. Now, the concept which you need to understand here is the hand is totally free in 360 directions. Whatever angle you want to give it, with the needle holder and the needle, you are free to do it. But that is not possible in laparoscopic surgeries, because there are 4 degrees of movement, and on top of that, ports are fixed, instrument length fixed, instrument movement, or you can say the degree of freedom is fixed. That is why it becomes a little bit challenging. So what it means is, in ideal configurations, doing it ideally, you can do good endosuturing. Otherwise, it won't be possible. So just to understand it, surgeon should be at the right place, and ports should be at the right place, just to simplify the fundamental of ergonomics. So what it means is, this is the ideal anatomical stance for the laparoscopic surgeries. Further elaborating, your arms, your shoulders, your forearms, your hands, your wrist movements, everything should be at ease. For example, if I ask someone to make chapatis keeping their hands above their shoulder, they won't be able to make it, right? For the sake of doing it, they will be able to do it, but ergonomically they won't be able to do it because of the tiring of the muscles. And that is why this anatomical stance need to be understood. So the ideal anatomical stance for laparoscopic surgery is, if we talk about arms, should be slightly abducted away from the body up to the tune of 20 degrees. Retroverted means a little bit backwards up to the tune of 10 degrees. Rotated inwards because the arm goes inside 40 degrees at the shoulder level. And the elbow should be bent at 90 to 120 degrees angle. You can see. Yes, ma'am. Hands, they also have a grasping position, which should be at rest. And there are a couple of important things which need to be mentioned, that the surgeon, the organ, and the monitor should be in the same line. Like this. Do you think this guy did a very good job? Yes, he did a very good job. But when he went home, he said, "Sweetheart, I'm having so much backache." No doubt he performed a very good surgery, but he got tired. Similarly, what is the distance from which you need to position your monitor? 4 times the size of the monitor should be the ideal distance from the monitor. The gaze should be around 25 degrees, or 10 to 40 degrees is the optimal, and it gives a lesser neck strain. And for example, in this situation is wrong because you're looking upwards. And the table height should be at the level of the waist, roughly at the level of waist, so that arms, hands, everything is at rest. And there are a few port placement positioning in which we say that the distance from the operating organ should be sufficient enough to see it from a legitimate distance. Because if you bring your telescope so near to the organ, you will see it's very big, and it is most of the times inoperable, it looks like. So if you see that uterus again from the port placed little bit cranial side, then you will see uterus seems normal. So there are a couple of angles which need to be maintained between the operating hands, around 60 degrees. Elevation angle is like angle between the horizontal plane and the instrument's axis. And similarly, the ports should be well balanced, half outside, half inside, and they should be in the radius of 15 to 20 centimeter from the organ we are operating. And these are the common port placement being followed in gynecological surgeries. 3 around the iliac lines, like this. 3 along the iliac lines, along the optic in the navel, like this. And maybe bilateral, one on this side, one on left side, and one on right side. And as Dr. Nutan Jain had propagated this, ipsilateral side. On one side, we are operating everything. So there is no ideal port placement as per the consensus of the surgical communities. But apart from that, it is also required that we need to have very good vision, very clear laparoscopic surgical field, area to be sutured, in the focus, in the center, telescopic movement, pneumoperitoneum, and ambidextry. So obviously, it's not the practice that makes it perfect, but it's perfect practice that makes it perfect. Thank you very much.
Dr. Nisha Kapoor, President-elect, Harobsgyncon, Dr. Nutan Agarwal, ex-professor, AIIMS, Delhi, Dr. Subhash Chawla, Professor and HOD, MMIMSR Surgery, Dr. Santosh Pasrija, and Dr. Seema Manoja.
Good afternoon, everyone. I thank Haryana Afghan Society and Dr. Ruby Bhatia ma'am for the opportunity to talk about robotic surgery in gynecology. I think the delay happened for a good reason, that every difficulty taking suture during laparoscopic surgery, the students haven't shown, okay, there is lots of angle is there, lots of maneuvers are there. But before I proceed towards how to do robotic surgery and basics and all, I'd like to know from the house, how many of you like drive a car? Can you please raise your hand? Okay. I think more than 50% are driving the car. It means you are having a good hand, eye, and leg coordination, so that you can sit in a robotic console and you can operate it easily, and you are more than 50% skilled to operate a robot. If you think about the laparoscopy surgery, the like learning curve is too much. Okay, if you compare to the robotic surgery, you can sit on the console, you can easily operate if you are playing video games or you are driving a car. Okay. So let's discuss. My outline will be history of robotic surgery, current trend, guidelines, and pre-op preparation, interrupt setting, and some videos. Okay. So as you know, from the history, surgery is evolving day by day, year by year. And from the maybe 800 BC, the first surgery, cataract surgery happened. After that, the place of surgery, the technique of surgery, as well as the instrument used for surgery has evolved a lot. So if you see, for the first time in 1996, the robotic console, it was looking like this, the primitive one. If you see the latest patient cart, it is completely modernized. And this is on the left side, this is the console, surgeon console, and the right one is the vision cart. So this is if you go to in our routine PGI, there are two consoles are there. And primary surgeon will be doing the surgery, and the students or any other secondary surgeon can sit and can guide the surgeon if required. And you can see the patient will be lying away from the surgeon, and you don't need to bend your hand, and you don't need to maneuver, and it will maintain the posture, and you can enjoy a cup of tea during doing a surgery. So if you see the history in India, the first in 2002, first cardiac thoracic procedure done. Yeah, for the first time for gynecological procedure happened in India in 2007. So if you see the number of Da Vinci system, they're gradually increasing over decades. The last 10 decades, there is 20 times increase in the number of system in India. And if you see the number of procedures done in specialty wise, urology, they are the topmost performer. Then the gynae comes in second. So this was the paper published in the multi-institutional trained in gynecology robotic surgery in India. Here we have compared the last 10-year data from 7 different centers of India. And up to 2019, the number of robotic surgery increasing in exponential manner, but however during the COVID the number was less. So what is the benefit of the robotic assisted laparoscopy surgery? This is the superior dexterity, intuitive movement, 3D vision, improved ergonomics, and autonomy of the camera control over the surgeon, and a short learning curve. So if you compare the robotic assisted laparoscopy surgery with the conventional laparoscopy, the robotic movements are filter of tremor. 3D camera is secured and controlled by the surgeon, providing stable view. Exact dissection by enabling depth appreciation. Operative strains like headache, dizziness, and eye strain is lesser in robotic surgery. So what ACOG and RCOG recommends? For malignant cases, CA endometrium, they have the good, strong evidence. For CA cervix, early stage of CA ovary, it is not recommended because you don't have the good evidence to support it. So for benign cases, RCOG has given a guideline that if it is a complex surgical procedure, like if there is a previous history of abdominal surgery or pelvic surgery, or patient BMI is more than 30, or there is a large retroperitoneal pelvic mass or posterior myomectomies, in those kind of cases, you can go for benign cases as well. And if you're planning to do tubal reconstructive surgery or sacrocolpopexy, then you can go for robotic surgery. So recently we have done a robotic surgery in 18th of this month. So this is the checklist that I found in our case sheet. So I thought I'll share with you. So this is the checklist before you take the patient to the OT. In OT instruction, you have to first identify the patient name and room number. Then for the resident, it's very important to note it because for any major surgery, 8 hours fasting is required. So we have told the patient to be NPO from 12 a.m. Then betadine scrub 1 day prior and the same day morning. Then parts preparation to be done from nipple to the mid thigh. And mesoprostral, if you are suspecting there is a difficulty during cervical dilatation, you can put mesoprostral 200 microgram at 10 p.m. and 6 a.m. And PC enema is given around 10 p.m. 5 a.m. And you have to do check the consent. Saman means drapes and ports and blood you have to arrange before the surgery. And injection cefirexime test dose to be given, and Pantop and Anxid to be given at the bedside. Omit morning dose of oral hypoglycemic agents and telmisartan because it will reduce the blood pressure during the surgery. You have to remove the jewelry and because if you put a jewelry, then it can cause a cautery burn. You have to put cannula and IV fluid 6 m the day of surgery, and gown and knee length stockings to be put before shifting the patient to the OT. Once the patient enters into the OT, then after the anesthesia is given, you have to put two towel just behind the patient, so that one is for stabilization and the second is tucking the patient's hand. And the hand should be tucked to the side of the palm facing towards the patient, and thumb should be up. And then comes the placing a port for the robotic surgery. Then 10 mm is the primary camera port, where you can just put just 3 to 4 centimeter just cranial to the umbilicus, and 8 mm lateral ports are put around 8 to 10 centimeter from the umbilicus. And on the right side you can put the similar kind of port, so that here we have used two robotic arms with one camera port, and assistant port can be put around 5 to 4 to 5 centimeter away from the midline, joining the primary camera port and the lateral port. So this technique has been applied for more than 300 cases while I was doing my training. Then we have published a paper on that. So it can be done by using two arms that can reduce the cost of the surgery. So I'll be showing the video here. We have done a case of CA endometrium, where we have just like a normal like a laparoscopy surgery. We have to start from the round ligament. We are using on the left side, it's a bipolar, this is the bipolar energy source. Here we are using 40 watt of energy, and on the left side you are using hot searer, monopolar seizure. Our setting is usually 30 watts, so that there will be no lateral spread of energy, and it will prevent any complication like ureteric fistula. Once the left side round ligament is done, we are creating a tunnel just below the IP ligament. You can see there is a wrist-like movement and just below the IP ligament, and we are trying to create a space so that we can coagulate the IP ligament without any injury to the ureter. And you can make it out that there is the easiest like wrist-like movement. You can do the maneuver wherever you want to go. And the same thing we are doing on the right side. And once the ureter identified the ureter, and we are trying to create a tunnel just below the IP ligament, and this from the above, one assistant is there who is like pulling up the IP ligament so that we can create the space. Okay. Once the IP ligament has been coagulated and cut, now we are trying to separate the broad ligament, so that we are going to skeletonize the uterine artery. And once it is done, you have to separate the UV fold from the uterine anteriorly. And as you know, after because of the pneumoperitoneum, you will get the easy plane, avascular plane, so that half of the job is done by the pneumoperitoneum, half of the job is done by the monopolar energy source. And this avascular space is very important to maintain, because bladder will go away without any injury to the bladder. So this is the monopolar seizure. We are using the energy source to just give small fire, so that it will coagulate the small blood vessels, and as well as it will cut the UV fold. So okay, once the bladder is pushed down, and for the resident to identify whether we have in the right plane or not, there is the vessels that's going longitudinally down over the cervix. This is the correct plane to identify and give a push to the bladder down. Here we are cutting the skeletonize the uterine artery, and we are separating the broad ligament, and you can see we are coagulating the this uterine artery on the right side, and with the help of monopolar seizure we are giving a nick, and you can easily angulate, and you can easily give a nick on the uterine artery. Once the uterine artery is done, we are trying to remove the lymph nodes, and this is easily done by this robotic arm, because a small amount of fire will reduce the blood loss, And you can see the external iliac artery, they are pulsating. We are doing very close to the external iliac artery. We are trying to remove the external iliac lymph nodes. And here in robotic surgery, you can do the maneuver whatever and wherever you want to go. You can, if it is a deep, the lymph node is deep seated, you can go deep and you can remove the lymph nodes. And once the lymph nodes are like completely separated from the underlying structure, the technique of retrieving the this lymph nodes are different. You can put it this lymph node inside a gloves or handmade some endo bag. And here we are using gloves to put this lymph node, and we are trying to remove it through the lateral ports. Okay. Once one side is done, then we are doing the same thing on the left side. And on the left side, we are trying to remove the internal iliac group of lymph nodes. And as you know, the retroperitoneal dissection is very easy by using this kind of advanced surgical techniques. And you are going to do less injury to the ureter and underlying vessels. So this small firing will reduce the blood loss, and you can finish your surgery without any much complication. And here on the left side, you are using endo bag that is prepared by ourselves. So okay, we can tie the endo bag and you can remove the this lymph nodes from the lateral port. Once the lymph nodes are done, and we are trying to like open the valve by using the same monopolar energy source by using the robotic arm. And we are just giving a nick over the anterior fornix, and we are trying to remove, once everything is done, we are trying to remove the specimen by the vaginal route. And here the endosuturing is very easy, because you can move your like needle holder just like a wrist-like movement. We are here we are using a micro needle holder, as well as Stratafix is used to suture the vault. And usually we don't close the vault, and we used to reef the vault all around. And here we have taken the suture from the uterosacral ligament, so that it will prevent vault prolapse later on. Once the hemostasis is completely secured, you can see it at the end of surgery. Okay, you can reduce the intra-abdominal pressure a little bit, so that you can check, okay, whether there is oozing there is there or not. Okay, this is the end of the surgery. Thanks. Okay. Yes. Actually, the console was there. I'll tell you. Yeah, steps are yes. Steps are similar, but surgeon will be sitting here, and they have the microphone. Once you are operating this, suppose the primary surgeon is sitting on the left side of this console, and they have the microphone on that. They will command to the assistant, and accordingly, they have the speaker on this system. No. There is a master console is there actually. Yeah, here. That's like a finger. You have to use your fingers to operate the master console, and accordingly the arms. The arms are there. This arm will move depending on the finger movement. Yeah, basic, almost similar. Yes, that is true. Yes. Yes. All directional movement. Suturing is very easy. Yes. For grade 3 and 4 endometriosis, it will be very helpful. Yes. Yes. Yeah, yeah. Much easier. The learning curve is very less actually. Yes, yes, ma'am. Yes, yes. Yes, ma'am. No, in no, definitely not, ma'am. If you are, yeah, definitely not, ma'am. Because Indian, yeah. But recently, the Indian are making robots. Probably the yes, the robots and instrument will be cheaper. Yes, ma'am. Yes, yes, ma'am. We are doing it, ma'am. Thank you, ma'am. Thank you, ma'am. Yes. Yes, yes. That's why I have not included this. And only endometer is indicated in this case.
Attention. Hello. Attention everyone. Link and the scanner for the quiz is shared in your groups. You can check your WhatsApp group for the link and the scanner for the quiz.
A very good afternoon, everyone. Attention, please. First, I would like to tell about the rules of the quiz. Attention, please. One thing, you have to log in. Just you have to scan the QR code. Then you have to attempt the questions. There are around 30 seconds to 45 seconds to attempt a single question. Not more than that. Then in between you have powers. Like pop-up wall is there, you have to take the power. And if you have any doubt, then you have to take 50-50 lifeline as well. Again, if you are going in a right direction and you are boosting the scores, then you have two pop-up walls. First is strike and second one is shield. Shield is like a protection. So better you can take the shield so that you can reattempt your wrong question. Fine? You can. आप क्विज के अंदर आपको पावर्स आएंगी, आप पावर्स आप ले सकते हो, उससे आपका जो आपका स्कोर है वो बूस्ट होगा. सेकंड आपको जो आपकी करेक्शंस होंगी, लाइक आप लगातार करेक्ट आंसर्स का इको इज देयर. We can see this. अगर मेरा ये स्क्रीन दिख जाएगा तो that would be better.
इसका सिम चाहिए ये वायर उस पे कनेक्ट करनी मैम वो बता देना उनको मैम वो टाइम शीट बता देना.
Time is 15 minutes. अभी टाइम अभी स्कैन स्टार्ट करो. For the moment we are.
इस पे क्या है? विंडो पी करना. विंडो पी सॉरी विंडो पी डुप्लीकेट में ओके है. अबे तो हुआ था पहले तो बिना उसके भी हुआ था. उसकी वायर कनेक्ट करके दूसरे में कनेक्ट करिए. क्या करना?
ठीक है. Either you can just give me 1 minute. Either you can scan QR code or just click on the link. You can join this. Till now 33 participants joined. Join code is 874585. I am repeating 874585.
मैम कोड बता दो, यहाँ लिख दूंगा मैं कोड.
87
कोड लिख देते हैं.
just 874585.
87
मैम नो नीड, आपका सीधा हो गया. 4585. Till now 36 participants joined.
तार छड़ी है आप हटा दो, नहीं तो आप लगा लो अपना वाला. हाँ लगा दो, मैंने रखी थी. मैं तार क्या किसी ने छेड़ी थी क्या? नहीं निकाल के अभी तो जस्ट प्रेजेंटेशन हुआ था इस पे. हाँ ये दो मुझे, जो दूसरा कोड है ना इसका. उधर तो ठीक चल रहा था. हो गया. वेट कौन सोर्स में आ रहा है? गया तो है इस पे, कुछ शो नहीं हो रहा है इस पे. ये स्मार्ट वाली एलईडी में इसी तरह दिक्कत आती है. हाँ वही एलईडी में इतनी दिक्कत आती है. नहीं अभी भी चल रहा था. ठीक है मैं वही चेक कर रहा हूँ.
How many of you are not able to join till now? 874585. Ma'am, no need. You are already joined. हाँ आप joined हो मैम. कितने participants हैं यहाँ पे?
हम होंगे अभी तो 80 के आसपास, पता नहीं कुछ शो नहीं कर पा रहे हो। मैम वो स्कैन तो वो भी होगा ना वहाँ पे, वो सब दिखता है, पॉइंट दिखते हैं यहाँ पे।
मैम दूसरी साइड लैपटॉप थोड़ा सा करना क्लोजर। ये तो लैंड बाय एडिटर है नहीं, यूएसबी तो उसमें ऑप्शन है, ये मेन एचडीएमआई का चाहिए रहा हूँ स्लॉट।
Shall I start? 2, 1. Just start.
सॉरी।
Shuffling the questions I shuffled. So that similar question cannot go.
वो आए थे लैब टेक्नीशियन ना. Only 2 minutes are left for the quiz. 2 minutes. Try to be fast. Only 2 minutes left in timing. Last 1 minute. Last 1 minute. Who is Ankit? Ankit. Okay. You are leading actually till now. So here we are ending the quiz. So here we have first and second winner, Mr. Ankit, Dr. Ankit, I can say, got first position in quiz. Out of 30 question, 27 were corrected. And Dr. Monica Katoria. Got second position. So first two will be awarded. Otherwise, Dr. Priya and Dr. Sanjam is third.
Dr. Meenakshi to present mementos to the winners.
MBBS from our place. मतलब अच्छी पढ़ाई कर रहे हैं.
आओ सिमरन आप भी आओ विदुषी सब आ जाओ मैम आ जाओ आओ मैम आ जाओ आओ ऋषु क्विज मास्टर प्लीज कम सेकंड प्रिया ये तो मेरी स्टूडेंट है ये यहाँ से हमारे पास से टीचिंग करके गई है
जी आंखें खोलो आंखें खोलो जी
token of regard for Dr. Simon, and it is a proud moment to inform everyone that she is selected by Health and Family Welfare for a national as a quiz master for National Quiz on Indian Academy of Pediatrics at Delhi.
At Delhi, we have. Thank you. What's her name? Simanjit.
She's always our quiz master. And the quiz is always made by my assistant professor, Dr. Rishu. She's a postgraduate and SR from